Okay, so let's start off. And let's just start with a little review. So Spencer, what does the P wave represent? What's happening in the heart?
Depolarization of the atrius.
I'm sorry, what was that?
The depolarization of the atrius?
Yeah, and that was the exact right question. When you say atria, just to let you know, that atria is already plural, it's plural of atrium. So you
I screwed that up.
redundant if you
So I
say
think
atrium.
atrium.
Yeah,
Atrium.
okay.
Atrium.
Atria.
Wait, so which is it? Sorry.
Oh, of the atria, because it's
Of the
both,
atrium.
if both left and right atrium equal
Got it.
the atria.
Okay, understood.
Yeah.
Thank you.
And then Riley, what is a normal PRI in this class? I mean, excuse me, normal P wave. How do we define a normal P wave?
Oh, gosh.
This is why we're doing it.
Yeah.
Review. Tell me what you remember, if anything.
And typically it's prior, it's prior to the QRS complex.
Correct.
And it's regular, so
What
it'd
does
be
it look like? What does it look like?
like a little, it's a very small little bump. It's quite a bit smaller
Is it
than,
a bump like this or a bump like this?
it is a positive bump, so.
There, that's the answer.
Yeah.
Okay. So remember in this class, the most important thing is a normal P wave is upright or positive is also a good way to say that. I know that many references say small and rounded, and I don't care if you include that in your answer, but for our purposes, we don't care that much about it. Okay. The main answer is upright. So Koa, where does the PR interval, where does it begin and where does it end?
So beginning of the P wave going on to the QRS, so that's like 3 or 5 boxes.
Oh, perfect, okay, you answered 2 questions for the price of 1, good job. And so another way to say that was perfect, would be to say from the beginning of atrial depolarization to the beginning of ventricular depolarization. And Andrew, when Koa says 3 to 5 small boxes, how would you say that in seconds? A normal PRI.
Oh, 0.12 to 0.2
Correct,
seconds.
excellent, okay. And then, Grace, what does the QRS represent?
What is that?
Yes, keep,
Depolarization of the ventricle?
perfect.
Okay.
So ventricular depolarization, correct. Okay, and Natalie, what is a normal QRS?
Less than 3.
Less than 3 what?
3 boxes.
Okay, and if you were to say that in seconds, what would you say?
Less than 0.12 seconds.
Perfect, okay. So remember, it's kind of an oddity that the QRS complex is defined by the amount of time it takes, which is a little odd considering what a sort of complex little structure it is, but that's how we define it, okay. So Cody, a Q wave, is it negative or positive, and where is it within the QRS if it's there?
Q is the first wave, and it's a negative reflection.
Correct. So if there is a Q wave, and there's not always in a QRS, it's the first negative deflection. And then, Chris, how would you describe the R wave?
R wave, in a normal QRS complex, the R wave should be positive.
Yeah, an R wave is, by definition, is always positive,
Okay.
okay? If it's not there, it's not there, but we never call a negative deflection an R wave by definition. And so the R wave is the first positive deflection within a QRS, okay? And then, Anne, what about the S wave? How would you describe the S wave?
Negative.
Correct, and where is it relative to the R wave? Yeah, so the S wave, if it's there, is the negative deflection after the R wave. Now, one of the peculiarities of it is, although we always call it the QRS complex, there doesn't have to be a Q wave, there doesn't have to be an R wave, there doesn't have to be an S wave. There has to be something, so one of those has to be there, but it could be the R, it could be the S, whatever, okay? So, Kyle, where does the ST segment begin and end?
It begins at the end of the QRS, which
Okay.
is the J point,
Good,
and it ends at the end of the T.
perfect, At the, what of the T wave?
The end,
Beginning.
beginning.
Yeah, okay, so it goes from the end of the QRS to the beginning of the T wave. And Spencer, how would you define a normal ST segment?
It's going to be, I don't know, ST segment, I can't think of the word. It's gonna be kind of along that line.
Yep,
An
yep,
imaginary
it's
line.
along that line, so it's flat along the
Rectangle.
isoelectric line, yeah.
Rectangle.
And if it's not normal, what do we call it? If it's above, what do we call
You could
it?
say an ST elevation or an ST depression.
Correct.
On whichever direction.
Yeah, and, again, this will become clear the longer we do this, but that implies that the ST segment is always parallel with the isoelectric line in order for it to lie flat. And as we already know, it doesn't. So if it doesn't, if the ST segment is either slanted up or down, then the significant part when you're looking for elevation and depression is the J port. Okay. And so Riley, what does a normal T wave look like? In fact, you can steal your answer from a normal P wave and give it back to me, and always.
Smaller than QRS complex, and it's positive?
Yeah.
Positive.
Bingo, bingo, okay? So the T wave is upright or positive. If it's not upright or positive, it's negative, or we'll say, and what we'll say then, it's either inverted, is sort of the formal term, or flipped. You'll hear that all the time. Oh, there's a flipped T wave there, okay? That's what that means. Gosh, what's left? Koa, where relative to the ECG strip is the relative refractory period?
It's right after the QRS, so is it going from the S to the T?
Mhm. So the relative refractory period, remember there's two parts of the refractory period. There's the first one, the absolute refractory period, but the one that we're most concerned about is the relative refractory period.
Is it the T wave?
What part of the T wave?
First half.
The first?
Second half, second half.
Second half.
Yeah, and again, it's sort of approximate, so if you were to draw the T wave, so it's like, it's usually there,
Oh,
okay? And
That's the
again,
absolute?
no.
no, that's the relative.
What's,
That-
where's the absolute other?
Okay, by the way, be sure to read this, and Carmen asked me to point that out to everybody.
Yeah, party.
Oh, yeah, good.
So, so here's the,
The right is the best one.
here's the P wave, PR interval, QRS, we'll just do an R and an S, T wave, okay? And usually the P wave is smaller than the T wave, but, so the absolute actually somewhat, is usually defined as beginning as soon as ventricular depolarization begins. Because if you think about it, at that moment when the ventricles are depolarizing, they can't depolarize again right away. So the absolute refractory period is from the beginning of the QRS to about the middle of the T wave, and then the relative is there. Okay? Okay?
Is it the relative refractory period where commotion reported, or is it the absolute?
What's the answer?
Relative.
And why?
Because that's when the heart's half polarized and half depolarized, and they're all trying to get polarized, correct?
Yeah, so my answer is not gonna be any sort of more formal than what you said. A good way to think about it is that some of the, during absolute refractory period, remember all that business about the activation gate, that little plug at the bottom of the sodium channels? At that point, there is no way, during absolute refractory, no way that any sodium ions are gonna be able to go through the sodium gate and try to depolarize the cell, okay? No matter how much electricity you hit, that cell with, that sodium channel is closed. That's absolute refractory period. And then what happens in relative refractory period, as the cells come back online, if you will, some of them are ready to go and some aren't. So if you hit them with electricity, some of them will go and some of them will depolarize and some won't. And that's a bad situation. That's how we end up with fibrillation. Yeah.
Why does the absolute refractory period not begin when the atria depolarize, like at the P wave? Why is it not until the QRS?
Well, because all the cells are ready to go, right? So if you hit, a good way to think about it, the cells, refractory means aren't responding to stimulus. And anytime during this period and this period, the cells are ready to respond to stimulus. You see what I'm saying?
Yeah, so you're saying that cells in the ventricles or in the atria as well?
Oh, yeah, okay, I see what you're saying. Yeah, if we were talking, you could go through the same, you're right, you're absolutely right. And we could go through the same process if we're specifically talking about the atria. But many times, such as now, we act as though we're talking about the heart as a whole, and what we're really talking about is the ventricles.
Okay.
So, yeah,
Thanks.
so good question. Okay, I think that's enough review. So what we're going to do today is we're going to start to put this together. And remember, our job this term is to look at an ECG strip, analyze that ECG strip, and come up with what it is. Is it a sinus rhythm? Is it atrial fibrillation? Is it ventricular tachycardia? That's our job this term, okay? So how do we do this, okay? So we're going to use a 5-step process. And every ECG, beginning ECG text has some version of this 5-step process. They may break the steps into 2 steps and call it a 6-step process, but it's all the same process, okay? Now, here are the 5 steps, and let me just talk to you for a minute about the value of having a specific process. What happens when you're learning ECG identification, learning ECG analysis, pretty quick you're going to start recognizing some things, and you're going to skip over the process and look and say, oh, that's a sinus bradycardia, okay? And you'll be able to do that without going through these 5 steps, okay? And it's very tempting to think, oh, I'm going to be able to like look at everything and identify everything. And the more you do it, the more you will be able to do this, is not have to go through a tedious 5-step process. You'll kind of look at it, make a few measurements, and know what it is. But I highly recommend really, even though it can be a little tedious, understanding what this process is all about, because no matter how good you are, and I really mean that, no matter how good you are, who you are, from paramedic to cardiologist, at some point or another, you're going to see a strip and you're going to go, wow, what's that? I don't know what that is. And if you don't have this process committed to memory or some variation of the process that works for you, when you get to those moments, you're not going to know what to do. You're not going to be able to get an answer. And the closer you are to the beginning of learning about ECGs, the more frequently you're going to bump into strips that you have no idea what they are. So you need to really memorize this process. So what is this famous process? The 5 steps are usually what textbooks will call step number 1 is rhythm. I personally find that a little bit misleading, because it's almost as though, remember, the whole point of this is after you do your 5 steps, you put it together and you come up with what the rhythm is. Is it a sinus tachycardia? So by saying rhythm on the first step, it's almost like saying that's the first step. But that's not what's meant by rhythm here. I think a better term for the first step is regularity, is it's what you're looking at on the ECG strip. Is it regular? In a minute we'll talk about what that means. Second step is rate. Third step is you look at the P waves, ask questions, analyze the P waves, PR intervals, and QRS complexes. So we're going to start with regularity. So step 1, you ask yourself 2 questions. Are the R to R intervals regular? Are the P to P intervals regular? This second part really won't make any sense to you until we start doing AV blocks, okay? Because up to that point, if the R to R intervals are regular, the P to P intervals will be regular. But when we get to AV blocks, you'll see why we have to ask it twice. Okay, so what are we talking about? So R to R intervals is the interval from one R wave to the next R wave. You take your calipers and you march it out, and you say, is the distance from on this R to R interval the same as this R to R interval the same as this R to R interval? Now, obviously, I hope it's obvious, we always say R to R intervals. Could you use the S waves? Of course. Just, pick some point on the QRS, and if you want to do the S to S intervals, that's fine. Okay? But we typically will say R to R intervals. Okay? The only way for a rhythm to be regular is if you march your way across the whole strip and it's equal all the way across. Okay? In a little bit we'll talk about, can there be a tiny bit of variation? And the answer on that's going to be yes, but we'll come back to that. For now, just think, oh, it's equal all the way across. Then the second part of this, which again won't make any sense right away, is you do the same with the P waves. Okay? Do the P waves march out? And when we say, do they march out, what we're really saying is, do they march out regularly? Okay? Now, that's easy, yes or no, but if the answer is no, if the rhythm is not regular, meaning you take your calipers and you say, oh, wait a minute, this R to R interval is greater than this R to R interval, then you have to ask yourself, well, if it's not regular, in what way is it irregular? Okay? And there's a couple different ways that irregularity can appear. One that we've actually already seen in some of the strips that we've talked about is that, yeah, basically, it is pretty regular. If we look at this half of the strip, we've got a very regular underlying rhythm. But if we look at the strip as a whole, if we say, does it march out regularly across the whole strip? The answer is no, because there's this odd pause in the middle, okay? So underlying might be regular, but as a whole, no, it's not. And so is the rhythm regular except for a pause, or maybe a couple of pauses? That's one way for it to be irregular. Here's another way for it to be irregular. So again, if we march this one across, a significant portion is pretty regular. But we can't say that the strip as a whole is regular because we seem to have what I'm calling for now, and later we'll give them a more formal name, oddball beats. Okay, we seem to have these oddball beats that don't follow the pattern. They don't march out regularly, and in this particular case, not only that, they look different, okay? So that's another way that, in case you don't know, there's the oddball beats. So that's another way in which the strip can be irregular. And now here's everybody's fave. Is the rhythm regularly irregular or irregularly irregular? And even though it may not seem possible now, the most useful phrase in the whole bunch of slides here is that term irregularly irregular. So what's that? This pattern here is irregularly irregular, meaning it's random. That's a good synonym for irregularly irregular. It's random. There's no rhyme nor reason. It's just weird. We can't, maybe there's a few that march out regularly, but then it's different. Then the next one is short, the next one is long, the next one is medium. There's no pattern to it. The official ECG phrase for it, I didn't make it up, is irregularly irregular, okay? And then you have to say, well, if there's irregularly irregular, we must have regularly irregular. And in this particular case, what that means is that, yeah, we can, it's not regular, but there's sort of a pattern to it. So we have, you know, 2 short, 1 long, 2 short, 1 long, 2 short. So that's another way that something can be irregular. So let's pull out our, if you don't already have it out, the handout and go to page 12. And I want you to look at strips 1, 2, and 3. Pick up your calipers. If you don't have your calipers, come borrow one of mine. And march out, and don't just do the first couple. Go across the whole strip and say, is strip 1 regular? If it's irregular, how is it irregular?
I feel like irregular would be a fun term to explain in court.
In what?
It would be a fun term to explain in court if you were to have to go to court.
Yes.
If it was
Well,
like a chart or something like that.
well, good luck with that. Okay.
Good. Good. That's regular.
So after you've done strip 1, make sure you do strip 2 and strip 3. Don't worry about strip 4 or 5. That's a different question.
You said strip 1 and then you said strip 4 or 5? Is that what
No,
you
no, strip 1, 2, and 3.
said? Oh, okay,
Yeah.
sorry.
Okay, even if you're not quite done, we'll discuss it as we go. So Ann, what'd you get for strip 1?
I think that's pretty darn regular.
Okay, and let me ask you something, because it's a significant question. When you say pretty darn regular.
There's a couple that are a tiny bit longer,
Okay,
but I
did
would
people
still say it's
find that?
regular.
Okay, and you don't have to remeasure it now, but do you remember how many small boxes it was irregular by? Anybody
I think it
remember?
was like less than
Yeah.
one.
So, this, we'll jump into it right now. How regular is regular? Okay, can we have any variation? Well, we're not talking about a metronome, okay? We're talking about the human heart, and obviously, even if you're sitting there at rest, there are still things that are happening within your body that are going to speed things up a little bit, slow things down a little bit, you know, respiration, change in parasympathetic, sympathetic tone, all these things are going to change it. So, our rule of thumb is this. At rates between sort of what I'll think of as kind of normalish rates, let's say between 50 and 110, you can have as much as 3 small boxes of variation and still say that's regular, okay? Now, the slower it gets, the more variation we can have because the distances between the R to R's are longer. So when we get really slow, like 30 beats a minute, we can have as much as 1 large box of variation and still call that regular. Conversely, the faster it goes, the more those variations count. So if you get up to like 140 or something and you're getting differences of 3 small boxes, that's irregular, okay? So you get a feel for it, okay? But this one, yes, it's regular. Okay, so Kyle, what about strip number 2? What do you think?
Irregularly irregular.
Yeah, this is irregularly irregular. There is no pattern. It is a random how they pop up. And then Spencer, what do you have for strip 3?
I put regularly irregular for strip 3.
Correct. We can't march it all the way across, so we can't call it regular, but it is irregular in a patterned sort of way. Okay? So, that's step 1, done. Now, the second step is the rate, and the rate is no different than when you think of rate. Remember, we don't have a patient, when you're looking through a book, you can't walk up to the patient and feel their pulse. And when you're looking, when somebody asks you from an ECG strip, what's the rate, again, you can't go feel a pulse, okay? Now, in real life, if you want to know the rate, what can you do? And it takes about a second. Pulse, or all you have is the monitor. What can you do? Look at the monitor. It gives you, right? It's telling you on the monitor, it's telling you it's 80 beats a minute or something. But you still have to be able to, when you analyze an ECG strip, you have to be able to calculate the rate, okay? There are 2 different methods, and you need to be good at both of them because some strips work better for one method. So for example, I most frequently, probably about 60 to 70% of the time, use the 6-second method. But for some strips, the 6-second method just doesn't work, and then I'll fall back on the boxes method. So I have to know both, you have to know both. We're going to start with what I call the boxes method. Who remembers one large box, so 5 small boxes, one large box, what part of a second is it? 0.2. So another way of saying 0.2 is 1/5. So every large box represents 1/5 of a second. So a little math problem. If you have, how many boxes does it take for 1 second? 5, okay? So five large boxes represents 1 second, and that's the basis of the boxes method. So here's how you do the boxes method. So here we have, these are the large boxes, okay, these lines here, and here we have our ECG complexes. Here's one, here's another, okay? Everybody following that? You find one of the R waves that lines up, like you scan across and you find one of the, it's my phone. You find one of the R waves that lines up with one of the large box lines. So this one lines up nicely. And when you have a whole strip ahead of you, you'll find one that lines up or is pretty close, okay? Then you start counting, and you have to have memorized the numbers, okay? So you go, here's our starting point. The first large box, and we're going to count over to here. The first large box is 300. The second large box is 150, and I'll explain the numbers in a minute. The third large box is 100, and then the next R wave lies between 100 and 75. Okay? So what that's telling you is the rate lies somewhere between 75 and 100. And then you kind of look at it and you say, is it closer to the 100 or closer to 75? So what do we think? Closer to the 100 line or the 75 line? 100. So I would say about 90, 85 or 90. And that's good enough. That kind of approximation is good enough. So the rate here is 85 or 90. So where do these numbers come from? What weird numbers. So here's the numbers that you have to memorize. And it really is easy. After you do it a bunch of times, you'll have it. So 300, 150, 175, 60, 50, 43, 37, okay? So the 300, what did we say, 5 large boxes equals how much time?
1 second.
is, excuse me?
1 second.
1 second, okay? Now, what we're interested in for rate is how many beats per minute, okay? So what we're saying, oh, if 5 large boxes is 1 second, 60 seconds in a minute, that's 300. And so what that means is that if your beats were coming like at the rate of the increment of about 1 large box, that's 300 beats a minute, which is impossibly fast, okay? If your distance between the R to R intervals is approximately 2 large boxes, then, here's our start, is 2 large boxes, then the rate is 150. 3 large boxes is 100, 4, 75, 60, and so on. You don't have to understand the explanation of why, you just have to memorize it. If you didn't follow that but want to go through it again, I'm happy to do it during the break, get it to the point where you understand that, okay? So that's it. So how do we do this? So I'm going to do one, and then somebody in the class is going to do the next. Okay, so here's our strip, and it's only part of a strip because I wanted to blow it up, of this. Which one do you think is closest to one of the large box lines? Yeah, I think the second one is. There's none that lie exactly, but this one, right there, is really close, okay? Everybody see that? Then what we're going to start doing is counting how many large boxes to the next. So here's 300, 150, 100. Oh, this is going to be really similar to the other one. 75, 60. So we know that our rate lies somewhere between 75 and 60, and what's it closer to? 75. So what do we think would be a reasonable number?
70.
Yeah, 70. So I think that's pretty good. Okay. Okay. So everybody can do it. Strip number 4. Okay, on your handout there. Find one that is close, and then use the boxes method. Yes, Cody.
Why would you do this instead of using your monitor?
Because you don't have a monitor.
Oh, but you just have that.
If I had a monitor, I would never fuss around with it. But for the whole rest of the term, and for a good portion of your career, you're going to be handed strips. And
Oh, I
so,
see.
yeah, good question, but that's the answer. Okay.
Can you bring back up that slide?
Yeah,
that has
that is-
the- I already forgot what is.
Yeah, good question. Good. There we go. Okay. So you start, are you asking where do you start? Where do you start?
Yeah, so it's your,
So you would
so
start
you're
like
picking,
which
so I'm
one is
picking
going
that
down?
one, and the next
The
one
next
is
one is
Clearly,
the-
thank you.
yeah.
Go the next one.
Yeah.
Clearly.
Yeah, that's not clear. This is the start.
Sit down, I can't.
So everybody got that? This would be the start, is the line before the 300. Okay, so then you count it off.
Do you have a way to remember the numbers, or you just say it?
You know, if you do it 5 times, you'll get it. So the only other way to do it is to calculate it, is to say, okay, if I'm talking about 0.2 seconds, how many increments of 0.2 seconds are in a minute? And that's 300.
That's a lot of math.
Right, and that's why it's easier to
Just
memorize it.
remember.
Yeah. Yeah, it doesn't, it takes, people pick it up really fast. And you don't use these quite as much, but at least, no, go all the way down to 37. So,
well, it's happening at every time, right? So it's-
no. See, it's half.
I know it messes up 75 to 60 or 60 to 50, right? That's the one.
Yeah, so let's just do it, and then if anybody wants to go through again, how do you calculate it? Let's do that during the break, because I don't want to spend time right now when you just have to memorize it, because like Cody said, it's too much math to do in the moment. You just have to know it. Okay, everybody got it? Anybody still working on it?
Set it up.
Okay.
I'm just saying, that's crazy.
Okay, who's got it?
90.
Okay, so which one did you use? Where's your?
I started at
Oh. Okay, go ahead, Cohen.
Started right here.
Okay,
It's like right next to the
Okay.
line. Then so 300, 150, 100, 75, and it's closer to 100, so I estimated it
Yeah.
to be 95.
yep, 90, 95, okay? And how good do you have to be? You have to be within about 10. So if we're getting answers that are wildly different, then we need to sort of, get a little better. Now, one other thing, but that was perfect, one other thing to mention is you can go either way. And what do I mean by that? You could take this one and go this direction, which is useful if the one that is right on the line is toward the end. You think, well, how can I do it? It's off the strip. But you can always go this way. You can say 300, 150, 75. See what I'm saying? You can go either direction. Okay. Fortunately, the 6-second method I think is a lot easier. So, but again, I'm going to emphasize you have to memorize those numbers. I expect you to memorize those numbers. Okay. The 6-second method makes use of the fact that an ECG strip is marked in 3-second intervals. Okay. Now these are old. Typically now you won't see these little triangles, but you'll see a line. So if you look in Huff, above every strip, you'll see they're called 6-second strips because they're actually a tad over 6 seconds. Like if you look at the strips in Huff, what a 6-second strip does is the line will be a tiny bit in from the edge this way and a tiny bit in from the edge this way. So a 6-second strip is really about 6.5 seconds, okay? And the distance from here to here is 3 seconds, the distance from here to here is 3 seconds. And this is true on all ECG strips, is they're marked at 3-second intervals, okay? So, here's the 6-second strip makes use of this fact. So what we do to calculate the rate, count the number of spaces. The R to R intervals, not the QRS complexes themselves. What do I mean by this? Yeah. Is what you're going to do is say 1, 2, 3, 4, 5, 6, 7. Now notice I did the spaces, not the QRS complex themselves, because there's actually 8 QRS complexes, but 7 spaces. It's a little bit more accurate if you do the spaces. Now, if you notice, I can take into account the fact that this one starts just a tad before the mark. But handily, this one just happens coincidentally, ends a tad before this mark. So in my mind, I'm kind of shifting it over and saying, oh, that's pretty close to exactly 6 seconds between this one and this one. You see what I mean? You have to take into account that they're not going to land exactly on the marks. Okay, you just have to kind of calculate that. And then what you do, because it's 6 seconds, and there are 10 6-second increments in 60 seconds, you multiply by 10. So in this case, 1, 2, 3, 4, 5, 6, 7, the rate is 70. Okay? So it's considerably easier and faster. And like I said, most of the time this is the method I use, but as you will find, sometimes the boxes one is the only one that works. And you'll see why as we go along. Okay, strip number 5. Everybody just take a few moments and using the 6-second method, calculate the amount, the rate.
We're not turning these in, right?
No, no, this is for you to keep. So take all the notes you want, okay?
I'm gonna take one home.
No, no, you're not like.
Why is it called six?
Strip work, that's 6 seconds.
June.
Multiply whatever count you
Okay, so Chris, what'd you get?
100.
Okay, so I'm going to start at this end just because this one is so close to the mark there. So I've got 1, 2, 3, 4, 5, 6, 7, 8, 9. But the mark is here. So actually, it's a little bit under 100. Can you see that? It's not. So I would have it more like maybe 95. Yes.
Ours is a little different. Ours.
Oh, do you have a different one there?
Our
Cody's splitting hairs at
last,
this point.
our last QRS is inside of that line on our page.
That's not
Mine looks exactly the same. Yours looks exactly.
Yeah, Cody,
You guys are smoking.
It's 95 to 100, okay? I mean.
Yeah,
we said that it'd be
95,
like-
yeah. Because we're learning it right now, it's 95, and if yours looks different, no, but you're,
Yeah, but that's like one.
It's 98.5.
The first one, dude.
98.5.
He's put in the last
Agree to
one.
disagree. 98.5.
It looks exactly the same.
Okay, then 96.
She said she'll go with it.
Yeah.
It's about 97.
okay, 97. We'll go with
I'll
97.
take it.
Okay,
The arrow separately from.
okay, let's go to something a little less controversial. So, Natalie, what's a rate called that's too slow?
Bradycardia.
Yeah, bradycardia. Bradycardia. Yeah. And Grace, what about a rate? Oh, we have to wait. The slow. Okay, there we go. And Grace, what's a rate called that's too fast? Tachycardia. Okay. And Andrew, bradycardia is a rate less than what?
60.
Okay. And Koa, tachy is a rate greater than what?
100.
Yes, 100. 100. Okay. Now, even though the previous slide implied when it's too fast, too slow, that there's a problem, that makes it sound like it's problematic. That's it could be said a little more clearly. It's a neutral observation. Okay. If a rate is slower than 60, we call it a bradycardic rate. That doesn't mean it's good or bad. When a rate is faster than 100, we call it a tachycardic rate. Might be good, might be bad, might be neutral. Okay? Okay, so that's rate. Let's see. Okay, step 3, and it will help you. By the way, these steps are put in that order for a reason. So when you do this 5-step process, you'll find it's more efficient if you do it in the order given. So step 3, we ask a lot of questions about P waves, and actually these are very similar. What you're going to see, these are really similar to those questions we asked last week at the end of class when we were doing that exercise. Okay, so are there any P waves present? Are the P waves upright? Do the P waves all look alike? Is there a P wave preceding every QRS? Is there QRS following every P wave? So let's see, I can't remember how let's set this up. Let's just do this together. So Cody, are there any P waves present?
Yes.
Yeah. Okay, so that's easy because that's all I'm asking. And then Chris, what do you think? Are there any P waves present here?
No.
No P waves at all. All we have is QRS complexes and T waves all the way across. No P waves. Okay? So the next question is, are the P waves upright? And Anne, what do you think? Are the P waves upright here? Can you see it? What's that?
No.
Correct. So no. So again, what are we looking at here? So we know where the QRS complex is, we know where the T wave is, and if you can see, there's a little inverted P wave. It may even be a tiny bit biphasic, maybe it goes down then up, hard to say. But at any rate, it's not purely upright, so the answer is no. Okay, and then Kyle, are the P waves upright here?
Yeah.
Yeah. Okay, and now do the P waves all look alike? So that's the next question. So Spencer, what do you got? Do they all look alike? Okay. Okay. And remember, I mean, I guess this is sort of obvious, but just remember, if you want to know if they all look alike, you have to look at all of them. Okay, so don't just look at like the first three and say, in this case, of course, you're right, they are all look alike. And Riley, what about this?
P waves look alike. Let's see. No.
No. I mean, this is really weird. Some of them are upside down, some of them are right side up. They're different sizes, different shapes. And next week, you'll learn what this is. Okay? But for now, all we're doing is answering the P wave questions. And then, Koa, what about, is there a P wave preceding every QRS?
No.
Okay, and which ones don't have P waves?
So this is a T, this is a P, and then there's a T, and then I don't see anything here.
Uh-huh.
This is a T wave. I don't see anything.
Correct. Okay, so these are the ones, exactly like what you said, these are the ones that are missing P's. And again, we don't quite know why that is. We'll learn about this one up next week as well. But in answer to the question, no. Okay, and then, yes?
How do you, on that last one, how do you distinguish that T from the P? How do you know that's not a P wave?
How do you know that this is a T and this is a P and this is a T, not a P?
Yeah.
Okay, so if you notice, the P waves that are there all look alike. And if, you know, in a word, this one is just way too big to be a P wave, okay? Is it impossible for a P wave to be this big? It would be unusual, but not impossible. But what would be highly unusual is exactly what we see, meaning all the P waves are like this, and then out of the blue, there's a big P wave. It's much more likely to be the T wave. The other answer is that while there are plenty of reasons why a P wave, like an individual P wave, might be absent, there's a bunch of reasons for that. I can think of no reason why an individual T wave might be absent, meaning if it's going to be there, it's going to be there all the way across. Okay, and then I think, Andrew, you're next. P wave preceding every QRS.
Yes.
Yeah, good job. Okay, and then finally, is there a QRS following every P wave? So, Grace, what do you think here? If you look at the P waves, does each one of them have a QRS following? Yeah, absolutely. Okay. And then, Natalie, what do you think here? So where are the P waves that don't have the QRS following? That lack a QRS, if you will. Yeah, I know, it's hard when you're just starting off. Yeah, Grace, go for it.
I'll get you back for next week. You have one right here.
Good.
And then also one right here.
Yeah, so these are what we call, when we have sort of There's two ways to talk about a P wave that has no QRS following it. Sort of the formal way to talk about it is a non-conducted P wave. What does that mean, non-conducted? What does that mean?
It's not conducted to the AV node.
There you go. So the atria depolarize, but then for some reason, that we'll learn about at a later date, the impulse just dies. The less formal way to talk about it is an orphan P wave. It's an orphan P wave. Yeah, go ahead.
So how would you said the U wave follows a T.
Uh-huh.
So how would that like look different?
Oh, that's a very good question. There's two answers, one of which will make sense now and one of which will make sense later.
Okay.
Typically, if there's a U wave, it'll follow every T.
Mhm.
It's I can't say never, but it would certainly be very rare just to have one little U wave pop up in the middle. Okay, that's the answer that hopefully makes sense now. The other answer is that even though this P wave is a little hard to see precisely because what's happening here is the T wave and the P wave are kind of not happening simultaneously, but almost, so that the side of this P wave has gotten cut off. But you can sort of picture how it should come down. You can see how it would be if the T wave isn't there. And if you look at all of these P waves, including these ones, the half-buried ones, they're the same shape, okay? So that's another reason, is it looks like the other P waves. It doesn't look like a U wave. And then the third answer, which will make, again, no sense to me, this is a form of an AV block, till we get to the AV blocks, is if you take your calipers and you march off the P waves, including the orphans, what you're going to find is they march out of them. Okay. And again, I don't expect you to remember that last bit. We're going to be doing that around Thanksgiving. Okay. But for now, the answer is you're not going to have an individual U wave with no other U waves, and it's the same shape as the other P waves. Yep.
So, in an exam scenario, would we go through and say if each part of it is regular or irregular, and then every single step, like, lists off, like, this is the rate, this is the...
I never have you do that.
Okay, so this is just more like so we can understand.
Yeah, so we can understand. Occasionally, I might ask you if something is normal or not, but by the time you're actually, next week, the only rhythms that you're asked to identify are sinus rhythms, and what I will ask you is, what is the rhythm? Are there any pauses or blocks? Which by the time you take the quiz, you'll know. But I never ask you to go through the steps you can do it on your own.
Yeah.
But I would never get them graded if for no other reason than that, if I had to do everybody's steps. So, but we do lots of practice in class, and so that's where if you're making mistakes on it, I'll pick it up there. Okay, we'll finish this and then we'll take a break. We'll finish this 5-step process. Okay, so PR intervals. So Spencer, remind me, what is a normal PR interval?
It's beginning of the P wave to the beginning of the QRS complex?
It's the beginning of the P wave, correct?
Yes.
But you're right, beginning of the P to the beginning of the QRS, but how do we know if it's normal or not? What's our criteria for normal?
The P wave is normal?
No, the PR interval is normal. I'll give you a hint, it's an amount of time. I guess that wasn't the best.
I get another one.
Somebody help him out, what is it? Yeah.
35 small boxes.
Yeah, 3 to 5 small boxes.
Okay.
And Andrew, what is that in seconds?
0.12 to 0.2.
Correct, okay. So,
Thank you.
yeah, so measure the duration. So what you're going to do in step number 4 is say, is the PR interval normal or not? Remember we did all this last week. Remember we sat there and took our calipers and said, is it 3 to 5 small boxes? Now, just for right now, why would a PR interval be too short? One is if the pacemaker, where in a healthy heart, Cody, where is the pacemaker?
The SA node.
Correct, okay. But let's say, for whatever reason, we don't know why at this point, doesn't matter. Here's our beautifully drawn heart, atrioventricles. Here's the SA node. Here's the AV node. Now, let's say that for some reason, the pacemaker is not where it's supposed to be, but it's really close to the AV node, okay? Or maybe it's inside the AV node. What that's going to do, it's going to shrink the PR interval because it's going to just take less time to get there. So that's going to lead to a short PR interval.
Is that just gonna be from like a congenital heart defect or?
No, it could be for ischemia, it could be electrolyte imbalance, it could be some tox issue, it could be that somebody has drunk a cup of coffee, it could be a benign thing that really doesn't matter anyway. So kids and young adults, a lot of times the pacemaker will kind of wander around the atria and it doesn't mean anything, okay? And it doesn't, you wouldn't feel it. So it could be, in fact, it would be very unlikely to be a congenital problem. It's probably some outside influence, inside influence, okay? So that's one reason for a shortened pacemaker. The next one I'm going to mention, just because I sort of feel obligated, it's an answer that I don't expect you to understand now. It's almost like a bookmark, a little mark that we're saying, we're going to come back to this in spring or winter term and talk about this. So don't worry about this second. It's just if we get to that point in spring and you say, why didn't you tell us about this? Well, I did. It's just, we're not going to explain it, okay? So bypass tract between the atria and the ventricles will also lead to a PR interval that's too short. So here, for example, is what I drew there, is if you have an abnormal pacemaker, it could lead to a shortened PR interval, okay? So in this particular case, I'm not even going to make you measure it, but if you, well, actually on your papers, take your calipers and you'll see. But what we have here is there's a little tiny Q wave, and then the P wave starts about here, and so this is a dramatically shortened PR interval. Okay? Now, I'm never going to make you say, I'm never going to say what is the duration of the PR interval. All I care about is it too short, too long, or normal, okay? And in this particular case, it's too short. Now, why would a PR interval be too long? Where are you going to see the PR intervals that are greater than five small boxes is if there's some kind of block in the AV node. So AV blocks, okay? And we'll get to that, like that's at the very end of this term that we're going to talk about AV blocks. Yeah.
For strip 6, they just showed, do you show where the P wave you're looking at?
Yeah, it's a little tiny inverted P wave.
So it's the first inverted.
Yeah, it's the little first inverted. Then I think there's a Q wave there, and so you just, to me it looks like it's only about one box.
Okay.
It's a really small PR interval. Okay, so if we have, oops, sorry, let's go back. If we have a block in the AV node here, what's going to happen, and for now we're not even going to talk about what kind of block, what kind of AV block it is, but if the impulse goes from the SA node down into the AV node, and instead of taking the normal pause, it takes an extended pause, a really long pause, what that's going to do is stretch out the PR interval. So if you, and we don't know what kind of AV block it is right now, but for now, if you happen to see, there it is, there's the block. So for example, here, look how long this is. In fact, this is an extremely long one, right? This is, what is this? This is like 5, 10, gosh, about 13 small boxes long. So this is an extremely long PR interval, so too long, okay? Okay, we'll do the last bit and then we'll take a break. So QRS complexes, Koa, remind us what's a normal QRS?
It's less than 3 small boxes.
Perfect, okay. Why would the QRS complex be too long? What do you think is happening? What has slowed down, for whatever reason, even if you don't know the reason, the underlying reason why it might happen? Yeah.
Well, now I'm thinking about it, now I think I might be wrong. But is it ventricular contraction is slowing?
You're almost right. Remember when we, on an ECG strip, all we see is what kind of activity? So what actually, so
Electrical
electrical.
activity, yeah.
Yeah, so if the QRS is stretched out, what has slowed down? Ventricular what? Depolarization. Depolarization. Okay, so remember that the QRS complex represents ventricular depolarization. If the ventricles are slowing down for whatever reason, okay, if it just takes longer for that electrical impulse to get through the ventricles, what's going to happen is the QRS is going to stretch out. Okay. Anybody know any reasons? I don't necessarily expect you to, but anybody want to take a guess? What might slow down ventricular depolarization?
The AV node takes too long.
No, because as long as the impulse is in the AV node, that's not ventricular. That would be an AV block. It has to get into the ventricles, has to get through the AV node before the ventricles start to depolarize. So, anybody know? Yeah.
Bundle branch blocks.
Bundle branch blocks. What else? Anybody else know? What do you think? Think about patients you might treat. Okay, a slowed ventricular depolarization is never a good thing. It's never one of those things where we say, oh, maybe it's a conditioned athlete. You know, some of these things are, like bradycardia. Not a wide QRS, not a slowed down depolarization. It's always because of some underlying bad thing. Yeah?
Like cell death, so it's a slower transmission.
Well, let's go once, you're correct. Let's go what happens before cell death. So,
Is it ischemia?
ischemia, brilliant, okay? So that's one thing. So here's our list. So ventricular rhythm, bundle branch block, electrolyte imbalance, and some drugs. And ischemia is also a very good answer there. Okay, these are the things that widen out a QRS complex. So what do we think here? Wide, narrow, normal, wide? Yeah, this is wide. Okay. And here, what do you think?
Narrow.
Yeah, this one's narrow. Okay. So one final note, and then we're going to take a break. It's funny, we go through the 5 steps, and there's kind of an implied 6th step as we take the 5 steps, put it all together, say after we've said, is it regular, what's the rate, what do the P waves look like, PR interval normal, QRS complex normal, put that all together, what is it? Okay, so that's our job. Okay, so let's take, I've got 9:39, 9:40, let's come back at 9:50. And
Again, like it all before.
Chairs and real hard.
okay, let's go. In a minute, we're going to start talking about sinus rhythms. But before that, I just want to make some general statement about cardiac dysrhythmias, okay? So when we talk about cardiac dysrhythmias, they usually have 2 words in the name, okay? Like sinus tachycardia. The first tells where the rhythm originates. What does that phrase mean? Where the rhythm originates? What does that mean? So for example, where do sinus rhythms originate? In the essay note. So when we say where does the rhythm originate, it means where is the pacemaker? So if it's ventricular rhythms, they originate, the pacemaker, for whatever reason, has moved down into the ventricles. So as part of the name of every dysrhythmia, the first tells you something very important, where the rhythm originates, okay? The second, so usually have 2 words in the name. There's a few that have 3, but not too many. The second tells you something about that rhythm. So if we say sinus tachycardia, so Grace, if I say sinus tachycardia, where does the rhythm originate?
In the SA node.
Okay, and Natalie, what else have I told you? What other piece of information have I passed along to you when I say sinus tachycardia?
Oh, you're telling us that it's fast.
And how fast?
Faster than 100.
Faster than 100. So it's when I say sinus tachycardia, the information that tells you is, oh, the pacemaker is in the sinus node, and the rate is faster than 100. So just to be clear, I know this is, sort of beating a dead horse, but oh well. Cody, sinus rhythms originate where? SA node. So the pacemaker is in the SA node, and then Chris, atrial rhythms originate where? In the atria. Yeah, I know, it's a trick question because it's so easy. So atrial rhythms, for some reason, the pacemaker has moved from the SA node down into the atria. Okay, we're not talking about reasons now, we're just talking about what it means. And then this one may not be quite so obvious. Who knows, when I say junctional rhythms, where does that originate? Anybody know? Yeah. Yeah, the AV node. Okay. So junctional, that's what it means, the AV junction. And then a little bit easier, and ventricular rhythms originate where? Yeah, in the ventricles. Okay. Now, what does the term supraventricular, Koa?
Above the ventricles.
Okay, above the ventricles. So, Spencer, which types of rhythms, think about, we now have said these are our rhythms, and these are either sinus, atrial, junctional, or ventricles, okay? Which of those would we consider supraventricular?
The sinus rhythms and atrial rhythms.
And?
Junction.
Yeah, and junctional, okay? Okay. Sinus, atrial, and junctional, and then Riley, if those are the supraventricular rhythms, which types of rhythms are not supraventricular? There's only one.
I'm sorry.
So if supraventricular means above the ventricles, there's only one type of rhythm that's not above the ventricles, and that's what? It's one of these dumb questions that's almost too hard because it's easy. Help them out. What is it? Ventricular. Yeah. So what I'm saying is that this is kind of really important distinction. This is going to become a very important distinction for us. And, it will become clearer the more we do it, but also I'm going to tell you another reason why on the next slide, is rhythms are either supraventricular, meaning sinus, atrial, or junctional, or they're ventricular. And that's a really important distinction. So, reminder, so Andrew, the QRS represents what?
Ventricular depolarization.
Okay. And a normal QRS, Grace, is less than how many small boxes? 3. Okay. And this means that in a healthy heart, it takes less than, Natalie, how many seconds to depolarize? 0.12. Okay. Okay. Important fact. Okay. So, all ventricular rhythms. Now, remind us, Cody, when we say ventricular rhythms, what does that mean? Where do those rhythms originate?
Ventricle.
In the ventricles. So any rhythm that originates in the ventricles, okay, ventricular tachycardia, accelerated idioventricular rhythm, have a wide QRS, okay? Any rhythm that originates in the ventricles have a wide QRS, okay? And so why would that be, okay? So we're sort of jumping the gun here because we're not going to talk about ventricular rhythms for several weeks, but I want you to know this fact because it's important, is that so here's our pacemaker. That's what this means here. This is the pacemaker, okay? It's down in the ventricles. We don't know why. We know it means something's wrong with the heart, okay? It's down in the ventricles. Any rhythm where the pacemaker is down in the ventricles will always have a wide QRS. And Koa, by wide QRS, what do we mean?
Greater than 3 small boxes.
Right, greater than 3 small boxes, okay? The reason is because typically ventricular rhythms originate from one or more, important phrase, ectopic foci. What does ectopic mean? Like ectopic pregnancy foci.
I don't know.
Yeah, or misplaced, okay? Misplaced. And foci is the plural of focus. Focus is another word for pacemaker. So when you put this together, it's a phrase we're going to use over and over and over, so you need to know it. Ectopic focus is a misplaced pacemaker. Anything outside of the sinus node is considered an ectopic focus. Anything outside of the sinus node is considered an ectopic focus, a misplaced pacemaker. Because in a healthy heart, it's the sinus node that's the pacemaker, okay? So, ventricular rhythms originate, this shouldn't be typically, it should be always, originate from one or more ectopic foci in the ventricles. So there's a misplaced pacemaker in the ventricles. Now, because it starts in the ventricles, it doesn't have the advantage of the speedy conduction system. To get on the speedy conduction system, the impulse has to come down through the AV node. If you start in the ventricles, you can't come down through the AV node because you're starting below the AV node. So what that means is the ventricles will still depolarize, even though the pacemaker is in the ventricles, but it's slow. It's that slow myocyte to myocyte depolarization, not the speedy conduction system. For that reason, any ventricular rhythm that has an organized QRS, like VTAC, will always, 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 always have a wide QRS, okay?
Can you
So,
say that again?
yes, any ventricular rhythm has a wide QRS, okay? Now, I'm not talking about VFib, because there are no QRSs in VFib, okay? Has to have QRS complexes. Like VTAC will always, there's no such thing as ventricular tachycardia with a QRS complex less than 0.12 seconds. It's impossible, okay? Okay, that's the easy part of the concept.
I have a question.
Yes, please.
Does that mean that every single wide QRS has the?
Is a ventricular rhythm?
Yes.
Nope.
Okay. So
And that's what the next one is going to be. Yeah. Unfortunately, the answer is no. It's harder, okay? Usually, not always, unfortunately, usually supraventricular rhythms have a narrow QRS. Kyle, can you remind us what first of all, what does supraventricular mean and what are the supraventricular rhythms?
Supraventricular is paced anywhere above the ventricles,
Okay.
and what's the second one?
What are the supraventricular rhythms?
Sinus, atrial, and junctional.
Correct. So another way to say this is that usually, but not always, unfortunately, sinus rhythms usually have a narrow QRS. Atrial rhythms usually have a narrow QRS. And junctional rhythms usually have a narrow QRS, okay? Now, let's think about that for a minute. The reason that, let's talk about sinus rhythms, is that typically what happens, why do they have a narrow QRS? Well, most of the time, the vast majority of times, the impulse races down to the AV node, pauses, and races down into the ventricles, jumps on the speedy conduction system, narrow QRS. That's most of the time what happens with a sinus rhythm. Atrial rhythms, let's say the pacemaker is here, okay? Impulse starts from the pacemaker here, goes to the AV node, goes down into the ventricles, jumps on the speedy conduction system, boom, narrow QRS. Let's say the pacemaker is here, a junctional rhythm. It fires off, goes down into the ventricles, jumps on the speedy conduction system, narrow QRS. Everybody following me? Because ask questions if you don't, this is an important concept. Yeah.
Not so much about exactly what you're talking about, but I think I'm just missing how this happens. How does the pacemaker just move? I get what causes that, but what?
There's a whole bunch of reasons. So one of them is, let's say for whatever reason you have a problem with your SA node.
Okay.
SA node is not firing, the rest of the heart's like, come on, come on. And probably at that point the AV node will take over. That's one reason.
So it's just a backup kind of.
Yeah, and let's say that everything, let's say there's serious problems with the heart and everything above the AV node goes on vacation. That's when maybe the ventricles will take over. Or let's say, here's another reason, let's say the heart is becoming very ischemic or electrolyte imbalance, and so things are totally out of whack. And when things are totally out of whack, that's a technical term, then what might happen is just because the heart is ischemia, all these other parts of the heart are going to start firing off, and maybe the one that eventually is kind of a fight in the heart of what pacemaker is going to do it, maybe the ventricular one, the VTAC one, is going to take over. So there's multiple reasons.
And nothing besides like originating from the SA node is sustainable long term.
No, that's not true at all. So, it depends, let's see. For example, if for whatever reason, I mean, they're not always like serious wrong things, but let's say for whatever reason your AV node takes over, you probably wouldn't even notice it, okay? People who, you will find plenty of patients who are in atrial fibrillation that are sustained life, so it just depends. That being said, the ventricular rhythms are not very sustainable for long. They might be for a while, but not for long. Okay. Now, does everybody understand why the supraventricular rhythms have a narrow QRS most of the time? Was that clear? But then I said usually, yeah.
So kind of going off Chris's question, I can't remember the right term, but you told us that with the automaticity, I think SA is like 60 to 100, and AV is 40 to 60. So does that mean when the AV takes over, it's only going to be within the 40 to 60 range, or like how does that?
So those intrinsic rates are a little bit deceptive because they are the intrinsic rates. Like even the SA node, if you go outside and start running around, your SA node's going to start firing off a lot faster. So the intrinsic rates, what that means is in the body, not on the table, not plucking out and putting it on the table, person at rest with not excessive parasympathetic or sympathetic tone, just ho-hum, okay? That's it. But if you, say, increase sympathetic tone, the rate's going to go up. Now, if you happen to be in a junctional rhythm or atrial fibrillation or something like that, if you increase sympathetic tone, the rate's going to go up even so.
It's not fixed.
It's not fixed.
They're all able to.
They're all able to go faster or slower. Yeah, it is a little deceptive. So, okay. So most of the time, a sinus rhythm will be narrow. But suppose sinus node fires off, the impulse races down to the AV node, there's a pause, it goes into the ventricles, and suppose there's something wrong with the speedy conduction system. Still a sinus rhythm. But suppose a bundle branch block, which is something wrong with the speedy conduction system. The impulse gets here and expecting to hop on the speedy conduction system can't do it. That doesn't mean the ventricles can't depolarize. It just means that don't have the conduction system, so we're back to that slow cell-to-cell depolarization, okay? Or let's say you have the sinus node fires off, goes down to the AV node, hops into the ventricles, and that person happens to be very hyperkalemic. What does that mean, kalemic?
Potassium.
Too much potassium. Well, if you have, potassium really affects the heart muscle a lot. If the person is hyperkalemic, what that's going to do is slow down depolarization. It'll still be a sinus rhythm, but it's going to have a wide QRS. So the reason I say that usually supraventricular rhythms, sinus atrial junctional, have a narrow QRS is if everything's good, if everything's working fine, then the QRS is going to be narrow, unless there is some problem with the conduction system in the ventricles. A term that we are going to use starting today is intraventricular. What does that mean, intra? Yeah, within the ventricles, conduction delay, okay? There are numbers of reasons why there can be conduction delays within the ventricles, and the umbrella term is intraventricular conduction delay, which none of us want to take the time to say, so what we'll call that is an IVCD, and that's a term that's used, okay? So if let's go back for a moment. The sinus node fires off, goes down to the AV node, hops into the ventricles, and there is some intraventricular conduction delay. Okay, we don't know, it's just an umbrella term. There's an IVCD. It's going to be a normal sinus rhythm with a wide QRS. Okay? So, and by the way, we're going to keep expanding on this idea and using this idea. It's not a simple one, but it'll start feeling comfortable, okay? So with an IVCD, the conduction through the ventricles will revert to slow cell-to-cell conduction, and the QRS will be wide. What are the causes? Bundle branch blocks, electrolyte imbalances, and drugs. Okay. Okay, so why would the QRS be too long? So, too wide? So when you see a wide QRS, either it's a ventricular rhythm, VTAC for example, or it's a supraventricular rhythm with an IVCD. Okay? And I know it's a complicated idea, but we're going to use it, and that'll sort of make it again a little more comfortable. So, all supraventricular rhythms have a QRS unless an IVCD is present. So what you're going to see when you look in your books on your references, you'll see sinus rhythm, QRS less than 0.12 seconds. And that's correct unless there's an IVCD present, okay? Okay, finally. So we're finally going to start talking about the cardiac rhythms. We've done all the background work, and we're going to start with sinus rhythms. So, Anne, sinus rhythms, where do they originate? In the SA node, okay? And Andrew, sinus rhythms are supraventricular, so most of the time they have what, narrow or wide complex? Narrow, unless, Chris, go ahead, Andrew. Unless what?
You sure?
Yeah, I'm sure.
IVCD.
Okay, good. Unless there's also some sort of interventricular conduction line. Okay. Sinoatrium node, this is a repeat located where the supraspina, vena cava, and right atrium meet. Only about half of the SA node is actually pacemaker cells, which is kind of interesting. Richly supplied with sympathetic, parasympathetic nerve fibers. Why is that? Why is the SA node so connected into the sympathetic system, parasympathetic system? Yeah.
I mean, for example, would be like fight or flight, right? So it's other, or like certain environmental effects, that can cause your heart rate to increase. So you can book it, or when you get nervous.
Yeah, that's what I do. I book it.
Yeah.
None of that fight it stuff. Yeah, absolutely. So here are the sinus rhythms that we're going to go through. So here's what we're going to do. We're going to go through each one, define it, And then with what time we have left in the period, we will practice. We'll probably spill the practice over till next week, okay? So, so we're going to talk about a normal sinus rhythm, sinus tach, sinus brady, something called sinus arrhythmia, and then finally sinus block, sinus pause, and sinus arrest. Normal sinus rhythm, there is a very good chance that all of us in this room are presently in a normal sinus rhythm. The rhythm is regular, okay? When you see normal sinus, take your calipers. Remember that's step number 1. You march it out. Should be regular within the limits that we set. So within 3 small boxes. By definition, when we say normal sinus rhythm, the normal part is the rate. It's not Brady, it's not tachy, within 60 to 100, okay? P waves, upright, little variation morphology, which means shape. They all kind of look alike, and 1 P for each QRS. The PR interval, by definition with a normal sinus, is normal. And then by definition, it's a supraventricular rhythm. The QRS is less than 0.12, plus there's an IVCD. This is a normal sinus rhythm, okay? And again, we're going to have lots of time to practice, so you're going to see lots of normal sinus. But we're just going to kind of move through all of them, and then we'll start practicing. The way I made this slide is I took the normal sinus rhythm slide, changed the picture, and changed the rate. Everything else is exactly the same. There's no difference between normal sinus and sinus tach other than the rate. It's greater than 100. You know, and if you have something that's right at 100 or right about at 100, you can pull out our favorite term, borderline. You can say this is borderline sinus tach. Okay? Here's sinus tach. Okay? So narrow QRS, it's regular. The rate is greater than 100. In this case, it's probably 10, 20, 30, 40, 50, 60, 70, 80, 90, 100, 110, about 110, 115. So it's greater than 100. Okay? P waves all look alike. There's 1 P wave for every QRS. The PR interval is normal and the QRS is normal. So, Cody, give me one reason why your patient or somebody might be in sinus tach.
An easy one is that they just got done running.
Okay, exercise, good. Chris, what's another one?
Stress, agitation.
Okay, agitation. Andrew, what's another one? It gets harder the longer we go on this, but we got lots on this list.
Stimulants?
Stimulants, excellent, excellent, okay. And what's another one?
Something, well, I was gonna say, certain other reasons of shy nature showed up me on.
No, that not with right. Good idea, but wrong. What else? What else?
Electrolyte imbalance.
Okay, let me put everybody out of their misery. So, okay, and this is not inclusive. I'm sure you can come up with more. Okay, so exercise pain, hypoxia, shock, some drugs, so stimulant drugs, agitation, caffeine. That's some drugs, nicotine, fever. Don't forget fever, hypovolemia. Okay, now. I have this here, this slide here for a reason. If you have a patient and they are in sinus tach, you walk in and they're just, you know, and they haven't just stopped running, but they're sitting there, okay? And they're in sinus tachycardia. You've been handed a clue, okay? You should never have a patient in sinus tachycardia without thinking about it, without saying, why is this person in sinus tach? And maybe, who knows, maybe they just stopped running, okay? But you should have in your head a list of these so you can say, wow, you know, have they just taken cocaine? Or maybe they're going into shock, or maybe they're dehydrated. You know, maybe they're elderly and in a care home where they're not getting sufficient fluid. Maybe they have a fever, yeah.
Kind of a silly question, but as far as pain, increasing heart rate and whatnot, is that directly dependent on your pain tolerance, or is that just how you manifest it exteriorly? Like,
How do
as
you
far
define,
as
how
like,
do you,
so.
let me throw it back at you, how do you define pain tolerance? I mean, I'm not trying to trip you up, it's just, how do you define pain tolerance? Because I find it an extremely difficult term to explain.
I mean, so like, so this is an extreme example, obviously. But like, take a punch to the chest from Mike Tyson to a professional boxer was gonna be much less painful than your regular.
Do you think so?
I mean, I would imagine so, because they're conditioned. Maybe not to Mike Tyson.
Well,
but
here's
to-
the deal. I mean, I don't want to make too big a deal about it, but I think it's very hard to define pain tolerance because I really do. Because in fact, your question, I'm not going to be able to answer your question because there are people who are, you say, what level is your pain? And they'll say 10 out of 10, and it doesn't speed up everybody's heart rate. Either they're all wrong or not. One thing I will tell you is that, and this is what I think of pain tolerance, is that there are clearly two really strong components to pain. One is the pain, the way that pain sort of enters your body from the pain receptors, the nociceptors, goes up your nerves, hits your brain, lights your brain up, okay? So that's one way that we experience pain. It's like the actual pain. But the other thing that goes along with pain is sort of fear, agitation, stress. We're scared, we don't know what's happened. And these are two really, really, really separate parts. And don't discount that stress part. So it's possibly, when I hear you say that, what I'm thinking is, well, maybe what's happening with Mike Tyson, maybe he feels it exactly the same way, but his stress on it is not as great. So is that pain tolerance? I don't know. So the one thing I will tell you is that I would never discount a patient who tells you they're in a lot of pain and then you look over and say, yeah, I don't believe you. Your heart rate's only 70, of course not. I think people respond in different ways. So. Okay. Anyway, I think from a useful field perspective, this is a good list to know. And like I say, it's not inclusive. I'm sure you can think of more. Okay, sinus Brady. Again, exact same slide, but the rate is less. Okay, sinus Brady, in this case, 10, 20, 35. Okay, so Riley, what are these here? Here's our P wave, QRS, T wave. What's this thing?
The U.
It's the U wave. Okay. Okay, is sinus Brady always bad? No, we know the answer to that. For example, probably sinus Brady. Okay. I used to put up, never mind, I can't remember. Anyway, I like Katie Ledecky. Common etiology, why are people in sinus Brady? Damage to the SA node, hypoxemia, increased parasympathetic tone, normal and conditioned athletes. Okay? Okay, so those three are pretty easy, pretty straightforward. Normal sinus, sinus tach, sinus Brady. This one's a little more complicated. So there are two types of, what does the term arrhythmia mean? Excuse me?
Irregular rhythm?
Well, it actually, the A, who remembers? Koa, you were really good on now I'm going to put you on the spot, on the medical terminology stuff. Do you remember what A in front of a term means? Oh, okay. Anybody remember? So A means no, or like apnea, okay? Pnea means air, A means no. So arrhythmia is a really weird term, and you'll see that arrhythmia, dysrhythmia, what does dys mean? Yeah, bad is good. So you'll see them used interchangeably, and arrhythmia is kind of an older version, and at one point there was a movement in cardiology circles to say arrhythmia is such a bad term. Dysrhythmia is, because it's not that there's no rhythm, it's dysrhythmia, and they never were able to change that. So arrhythmia, dysrhythmia are pretty much interchangeably used, So sometimes you will see this called sinus dysrhythmia, but sinus arrhythmia is a little more common usage. They're the same things. That being said, whether it's sinus dysrhythmia or arrhythmia, there are two different types. By far the most common and the benign one, the one that is totally benign really, is respiratory sinus arrhythmia. I'm quite certain that if we put all you on monitors, that some of you would right now be in respiratory arrhythmia, sinus arrhythmia, okay? Frequently occurs in young adults and children. In a minute, we're going to look at it and say what it is. So what's happening with sinus arrhythmia is that the heart is responding to respirations, okay? And then non-respiratory sinus arrhythmia, far less common, almost always a sign of underlying pathology. So let's look at it. Respiratory sinus arrhythmia, regularly irregular. The rate is 60 to 100. It's really rare to be able to see sinus arrhythmia with tachycardic rhythms. P waves, again, the rest of it is just a sinus rhythm, okay? It's respiratory sinus arrhythmia is a normal sinus rhythm or a sinus brady that's made irregular by respirations. In all other ways, it's the same, caused by respirations. So what happens is the heart rate decreases, the heart rate slows down on expiration because of vagal nerve stimulation. So there's a little more parasympathetic tone on expiration, and then it increases on inspiration when the vagal nerve is no longer stimulated. So that's what's thought to cause it. It's very hard to see in a 6-second strip because you need to see a little bit of it. I think this is about a 10-second strip, and you can kind of see it here. So you can see, if you compare, you see how the intervals here are shorter than the intervals here. You can see how the middle part is, so this would be expiration, the vagus nerve is being stimulated, inspiration, no vagal nerve stimulation. So I will tell you now, you need to know what respiratory sinus arrhythmia is, but I'll never give you a 6-second strip and ask you to identify it. Because I don't think it's fair. Because if you think, oh, I'm just going to cut out 6 seconds, it's really hard to see that respiration pattern in 6 seconds. Kind of hard to see it in 9 seconds. You really actually need more than that.
So you say it's common. How common is it? Is there any kind of
I
figure?
think most kids are in it. I don't know about young adults, but I think it's far more common for kids to be in respiratory sinus arrhythmia than not.
But like you could probably feel that on yourself just checking your pulse, can't you?
Well, I don't know. Could you? So let's see. So this one is 300, 150, 175. So this is 75 beats a minute. This one is 300, 150, 70. So 300, 150, 175, 60. So you're seeing the difference between about 60 and 75, but it only is hanging out for a few seconds. You might, if you're really good at it and take a lot of pulses, I think you might notice the irregularity. I think you would be hard put to say. But then, I don't know, you might look at the breathing and see how it goes.
The only reason I ask is because I've noticed that on myself for
There you
a
go.
long time, and I just thought that was totally normal.
Yeah, okay. It is totally normal. It's completely normal. This is a very benign, normal thing. It's just, the younger a person is, the more, kids have a lot of parasympathetic tone, so, yeah. Okay. Far less common is non-respiratory sinus arrhythmia. It has nothing to do with respiration. Nothing to do with respiration. It's a random pattern. This is one of the irregular types. It usually is either found in elderly and sick elderly, not just plain old elderly, but sick elderly, and maybe an indication of a brain injury. Okay, so for example, here's an example of non-respiratory sinus arrhythmia. It has nothing to do with respiration, it's just weird, okay? If you're transporting somebody that has a brain injury, that's your most likely time to see non-respiratory sinus arrhythmia. Again, it's not common, okay? So let me repeat, I want you to know what these things are. If I ask you what they are, I want you to be able to tell me, but I'll never give you a 6-second strip of either one of these, because I don't think it's fair. You just can't tell. And also, especially this one, if you don't have the patient history with it, it's really hard to tell what it is. Okay. Sinus block, sinus pause, and sinus arrest. So sinus block, sinus pause, and sinus arrest are all recognized by an interruption in the regularity of sinus rhythm. So in this case, is this regular or not regular? Well, if you were to take your calipers, I think you would find that the underlying rhythm is regular, but then there's this pause in the middle of it, okay? So what is that pause about? Well, sinus block. Now, first of all, I'm going to tell you what sinus block is, and I'm going to tell you what sinus pause is. I'm going to tell you what the difference is, and I'm going to tell you I don't care about the difference. They're so close to the same thing that you can call them either one. Okay, so I'll tell you what they are, but then I'm going to say, call them either one. Okay? So what's happening with sinus block? Do you remember I said the SA node is made up only about 50% of pacemaker cells? And the rest of it is kind of the surrounding, so I think of it as the protection of the pacemaker cells and the gate to the pacemaker cells. So the pacemaker cells are where the impulse develops, but then it has to exit the sinus node. Okay, we think of it as so small, we don't even think of it as something you have to exit, but you do. The gate has to be open for the impulse to get out. Okay, so typically what happens is the pacemakers, let's say they're pacemaker cells, let's say they're throwing out impulse, let's say it's 60 a minute. They're just doing their job, throwing out the impulses. In order for everything actually to be working, is the gate of the SA node has to be open. And every once in a while, the gate stops working. So the problem is not with the pacemaker, it's with the sort of the structure, the surrounding structure of the SA node, okay? So the SA node discharges an impulse that's blocked. That's why it's called sinus block. The gate is closed, it's blocked. The rhythm resumes in step. So what happens is the pacemaker cells just keep throwing out the impulses at a regular rate, but you don't see them on the ECG strip because a couple of them are blocked. But when they start up again, when we see them on the strip, they're right in the right pattern because the pacemaker cells have just been doing their thing and making sure that they're firing off regularly. Okay. So, and it's not really serious unless it happens so much to cause a bradycardia. It's not clinically. There's very little importance to a sinus block. So here's my picture of what's happening. So these are just the QRS complexes. I know there should be P waves, but we don't care about that. I'm just showing the QRS complexes. So typically, the SA node's just firing off. Everything's great. But then what happens is that we're now going to have a sinus block, okay? So the SA node does its job for 2 times, and then it's still, if you watch, it's still going to be it's still doing its job, but the gate's closed, and then the gate opens, and then we're back, okay? With a sinus block, the QRS complexes after the space march out evenly, okay? So if you take your calipers, what you're going to see with a sinus block is you march it out, then there's this funny pause where nothing's happening, and it comes back in at the right time. Okay, that's a sinus block. So here we have a sinus block. You can see the underlying rhythm if you march it out, and then it comes back in right about at the same time. So our assumption is that the pacemaker cells within the SA node are still firing off. One of them was just blocked. Why does this happen? Although on here, some of these are serious, the truth of the matter is there's probably a whole lot more sinus blocks happening than we realize, because my guess is if you just skip a beat, unless it's a bunch of times, it just makes no difference. You may not feel it, you probably won't feel it, or if you feel it, you think, oh, palpitations, So it's a very, unless it happens a whole bunch, clinically there's no significance to it. Okay, sinus pause and sinus arrest. In this particular time, it's the pacemakers themselves that stop. Okay, so nothing about gates or any of that stuff. And really, the only real difference on the ECG strip is that the rhythm will resume out of sync. And a lot of times when it starts back up, it starts slowly. Okay. And a sinus arrest is simply longer. And of course, a very reasonable question from you is, how much longer? And to be honest, I don't know, because it's one of those things that's not clearly defined. So I like to think if the pause goes on for 3 seconds or more, let's call it a sinus arrest. Okay, so sinus pause and sinus arrest. There's the SA node doing its job. And then it just stops. There's no little firing within it. It just starts, and then it starts again. And when it comes back, what you're going to see is that it doesn't come back in sync, and a lot of times it comes back slower. Yeah.
So does sinus arrest precede like atrial thing?
No, none of these, unless it goes on for really long, and then it's probably not likely to proceed.
So if it doesn't, if the sinus doesn't come back, so if the pacemaker
Oh, I see why you're
stops,
thinking that.
does
Oh, you
that-
mean if it just stops?
Yeah. So in complete sinus arrest, would that?
Well, probably wouldn't. It probably wouldn't
Or
proceed.
would that be like
AFib.
junctional?
Probably would go. It depends on. See, it depends on why it's happening. And if something really serious is happening, my guess is it would go right into the attack. Okay. Yeah.
So in like a long sinus pause, sinus rest,
Uh-huh.
I mean, it lasted like over a second and a half. The patient's gonna feel that, because nothing's firing.
Not if there's, they probably won't feel it. They probably won't feel it if there's only one. I mean, they may feel it, but then if everything comes back and it never happens again, it's probably just not a big deal.
Is that gonna induce like any kind of like quick chest pain, like or?
I think it depends. It would probably depend on two things: how long it goes on for, and if for example, maybe the AV node, maybe it's a relatively healthy heart, maybe the AV node, maybe the heart goes into a junctional rhythm for a little bit, and then the sinus node comes back, and then they probably wouldn't feel a thing. So it would probably depend on how long it goes on for, and what state the heart is in going into it. So, but again, here's a sinus pause, and you can see it doesn't come in quite on time. It also comes in pretty slow. You can see there's a pretty big gap, and then it starts up again. Now, there's something like this, I don't think you wouldn't feel. Here's a much longer one, and I probably would call this a sinus arrest, because it's almost 3 seconds. Okay. So why do these happen? Again, many times very benign things, increased parasympathetic tone, and then some not so benign things. So I guess what I'm trying to say is it's not, all of these things could be a sign of underlying problems, but it's pretty rare that a sinus block or a sinus pause or even a relatively short sinus arrest causes problems on its own. Okay, it's more of a symptom than a problem. Yeah.
What does parasympathetic tone mean?
So, what's the difference between the sympathetic system and the parasympathetic system? Who knows?
Resting digest.
Okay. Yeah. So parasympathetic tone, in this particular case, it would probably be because parasympathetic tone, it affects the heart through the vagus nerve, so it'll probably be some kind of vagus nerve stimulation that just
Like
slows.
activation. Is that what tone means? Like the parasympathetic
Yes,
nervous system
yes,
working?
yes, yes,
Okay.
yes.
Okay.
Okay, yeah. Okay, now in this class, I've just told you what a sinus block is and a sinus pause and a sinus arrest. And the truth is, clinically, these things, whether it's a block, sinus block, or a sinus pause, clinically, it makes no difference, no difference. Plus, they're kind of hard to tell apart, because I gave you kind of the rules. They come in at the right time, they slow down, but a lot of times it'll sort of be in the middle between the two. So I don't want you spending any time trying to decide if it's a sinus block or a sinus pause or even a sinus arrest. In this class, I'm totally happy. Grab one that I usually will say sinus block because that's the more common one. But if the way that I would identify this is I would say normal sinus with a sinus block, done. If COA says normal sinus with a sinus pause, great job. It's a little bit short to be called a sinus arrest, but even so, the distinction clinically just makes no difference to us. Okay? Okay. I'm just going to I've stuck this in, even though this isn't a true dysrhythmia. Okay, sick sinus syndrome is an underlying disease that's characterized by sinus node dysfunction. Okay, sometimes it just leads to bradycardia. So if you have a patient who is bradycardic and it seems to be bad bradycardia, it could be caused by sick sinus syndrome, meaning they have a problem with their sinus node. You're not going to know that's what it is. You have no idea that's what it is. Most commonly seen in the elderly. So some possible causes, senescence simply means aging. So sometimes when people get old, their sinus node just starts functioning poorly, and maybe they'll get a pacemaker, a implanted pacemaker. Here are some other problems. ECG abnormalities may be variable or intermittent. So all of these things can be caused by the underlying problem of sick sinus syndrome. In that particular case, you're unlikely, you will have no idea if you see sinus brady. Like I said, that it's sick sinus syndrome. By the way, what does syndrome mean? What's syndrome?
Collection of symptoms.
Brilliant, good. Okay, the one reason I'm mentioning sick sinus syndrome really is because this is pretty rare, but you might see it alternating bradycardia with tachycardia. Let's just look at it. If you see something like this, where it's slow, it's fast, it's slow, it's fast, it's slow, it's fast, that could be sick sinus syndrome. And in this particular case, just get them to the hospital. Okay, it doesn't make sense to treat the bradycardia. It doesn't make sense to treat the tachycardia. So here's another example. Brady-tachy syndrome. It's a version of sick sinus syndrome. Here's another example. Here's one. Now here's with a really long pause. And it looked like in this particular case, it looked like they went right back into a sinus rhythm. Okay, we don't need to worry too much about sick sinus syndrome. It's not that common. And even if it's probably more common than we know, but it usually is something we can't identify in the field. Really, the only reason I'm mentioning it is because of that Brady-tachy version. Otherwise, there's no reason to mention it. Okay, so